Thank you so much, sir. We'll move on to the next session. This is the International Cooperation and Collaboration in Cardio-Oncology. And it gives me great pleasure to introduce our chairperson, Dr. Sheila Sawant, who is the professor and head, Department of General Medicine at Tata Memorial Hospital, Homi Bhabha National Institute, TMC, Mumbai.
So, very good evening to all. I would like to thank Dr. Parikh sir and Dr. Vivek Agarwala for giving this opportunity. And we are coming to a very important and interesting session where the international experts will be sharing their experience in different fields. So, the first speaker is Dr. Susan Dent. She is a pioneer in cardiology. She's different in the sense that she is among all the cardio-oncologists which I see in the Western world. She's a medical oncologist with an expertise in breast cancer. She's currently attached to the Wilmot Cancer Institute and director of the Cardio-Oncology program and professor of medicine at the University of Rochester, USA. And also we need a special mention that she was the one who has pioneered this field of cardio-oncology. She started with the Canadian Cardio-Oncology Network and went ahead to form the ICOS and was the president, and has just recently we have the new president, Dr. Michael Fradley. So over to Dr. Susan Dent. She'll be talking on quality indicators in cardio-oncology. So can we have Dr. Susan Dent?
Thank you so much. Can you hear me?
Yes, we can hear you.
Great, thank you. Thank you for inviting me. Sorry I couldn't be there in person. So I am going to spend the next several minutes talking about quality indicators in cardio-oncology, and I think this follows very well our last talk, talking about the importance of collecting data. Now we're going to talk about how do we evaluate what we're doing in the clinic. These are my disclosures. So we've seen the number of cardio-oncology centers and programs expand widely across the world, including China, India, North America, South and Central America, Canada, the US, and there are many more hearts that could be probably put on this map. And this certainly is providing access to cardio-oncology care for a number of patients worldwide. However, one of the questions that has arisen over the last few years is, how do we measure the benefits of a cardio-oncology clinic or program? Now, these are some of my viewpoints. One way we might be able to do that is look at how, from an oncology perspective, are we able to complete the prescribed cancer therapy? So that could be an indication of success. Do we see improved cancer outcomes? Or do we see improved cardiovascular outcomes or prevention of cardiovascular disease? What about prevention of long-term sequelae of cancer therapies, in particular, valvular heart disease that may not occur for several years? And importantly, what is the satisfaction of our patients who are referred to our cardio-oncology clinics? Are they happy with their care? And is this leading to better outcomes for them in terms of their own personal sense of well-being? Well, one of the issues is that there's very limited supporting data in this field. And so this was really the impetus that led to this paper called Quality of Care Measures for Cardio-Oncology. This was an initiative from ICOS and the ACC Cardio-Oncology Leadership Council, just published in April of this year. And really the goals behind producing this document was to address the current lack of measurable high-quality metrics in cardio-oncology and its implications, to highlight some of the needs and barriers specific to this area. So as cardio-oncology is a little bit unique, what are some of the quality indicators we might measure, to illustrate the development and application of measurable quality metrics, and really to provide a framework that demonstrates the value of cardio-oncology to patients with cancer and cardiovascular disease, to allied healthcare providers, but also importantly to administration. So as we're setting up these programs throughout the globe, administrators want to have also an understanding, is this really a value added for patient care? Are patients better because they've been seen in cardio-oncology? Are patients satisfied? And those are some of the realities that we face when we're looking at not only developing a cardio-oncology clinic, but how do we sustain a cardio-oncology clinic or program? So how do we measure success in cardio-oncology? I think this is a question that's very timely and that one we're just beginning to address as a discipline. The growth in cardio-oncology has traditionally been measured by the number of new clinics or number of new patients. We call that in the US the service line. And as you can see in this diagram, that's really focused on quantity. So how many clinics you're doing a week, how many patients are you seeing? But we know that as the number of clinics grow, the field is now hit this what I'll call inflection point, where we're now shifting from, is it not just seeing patients in the clinic, but are we providing good quality care? So we need to develop metrics that measure that quality, including key elements of quality care, including relevance, timeliness, safety, effectiveness, and equity. And these metrics need to be specific, attainable, and cost-effective while minimizing additional burden to our patients or caregivers. And because of the, as I'll show you in a minute, sort of the lack of a great deal of high-quality evidence, there are currently no clearly defined performance metrics in cardio-oncology. We are starting to develop those, but it's really an emerging area. So in this paper, the authors looked at ways we can assess quality and improvement specific to cardio-oncology. And they looked at two different models. One's called the Institute of Medicine model, one's called the Donabedian model. And in these models, for instance, in the Institute of Medicine model, or called the STEEP model, if we think about cardio-oncology, some of the things that we may be able to measure are safety, of course, reducing morbidity and mortality of cardiovascular toxicity, effectiveness, accomplishing the intended purpose, such as screening for high-risk patients, patient-centeredness, considering patients' needs, concerns, and preferences, timeliness. So are we avoiding delays in diagnosis and therapy? And from an oncologist's perspective, are we avoiding delays in cancer therapy? Efficiency in terms of resource use and equity deliverable of care. And we know that certainly that is a big issue, particularly in lower and middle income countries. And then the Donabedian model looks at three sort of areas, including structural measures, process measures, and outcome measures, and focuses on things such as, is there a formal service in cardio-oncology? What are the percentage of patients undergoing baseline cardiovascular risk assessment, and percentage of patients completing cancer therapy? And that could be an outcome measure, as I previously mentioned. However, also complicating when we think about quality metrics in this discipline, we have to ask ourselves, who will measure this data? How will we measure quality in the context of late effects? Because we know some of our patients will have cardiotoxicity effects later, many years later. And when looking at outcome measures, if a center is not meeting those measures, what will we do with that data? What if we fall below a defined quality metric? How will we deal with that? And so this group sort of looked at, using the American College of Cardiology and other venues, looked at how we can construct quality of care measures in cardio-oncology. And they broke it down into constructing metrics, determining feasibility of metrics, and measuring and evaluating metrics. So for instance, constructing metrics would mean defining your target population, in this case our cancer patients, identifying dimensions of care, looking at the evidence that's available now, synthesizing looking at the evidence in the literature, and then defining those measures based on what's in the literature. Determining feasibility, so what is feasible to measure in a clinic, what sample are you measuring, and then importantly, evaluating those metrics, developing a reporting unit and determining the number and range of measures. So they specifically talked about the ASCO guideline, which was published in 2016, and how the evidence that they produced. Now that's an older guideline, which was focused mainly on anthracyclines and HER2 target therapies. And then of course the ESC guideline published in 2022 and had many recommendations, 272. But when we look at those recommendations, we have to understand that about 3/4 of the recommendations in that document were based on level of evidence C, which means derived from retrospective or small studies or registries. So when you're developing a quality metric, you have to keep that in mind, that so far to date, we have a limited amount of level 1 evidence in cardio-oncology. So this is somewhat small to read, but I just really wanted to highlight what the crux of the document was to, as a group, come up with what was felt to be reasonable quality index measures in cardio-oncology. So each member of the writing committee of this paper identified their top 5 recommendations, considering factors such as practicality, achievability, impact, and measurability across the different settings. And the one that rose to the top from all our membership of this paper was risk stratification. And we know that this is highlighted in the 2022 ESC guideline, but this also was felt to be important in terms of a quality measure. So risk stratification before starting potential anti-cancer therapy. Of course, the ASCO guidelines also speak to who is at high risk, but we know within the ESC guidelines that they have risk proforma that if you apply these to the cancer therapy an individual is receiving, will place patients at low, medium, high, or very high risk, therefore stratifying them so that they can be referred to the appropriate provider in cardio-oncology clinic, particularly in the high-risk group. So this could be a potential quality index. Did they have a risk assessment prior to the cancer therapy? And this also aligns with the ESC Cardio-Oncology Quality Indicator data that has been published. And then the second most voted quality indicator was a health status assessment. And this does make sense. So at the beginning, before a patient starts cancer therapy, we need to do a comprehensive assessment, including a detailed history of their cardiovascular risk factors and disease. If they are exposed to a drug that may cause LV dysfunction, doing an echocardiogram, all prior to their cancer therapy. So did they have a proper cardiovascular assessment before cancer therapy would be another possible quality indicator. And then in terms of diagnosis, did they have an echocardiogram at the end of completing anthracycline chemotherapy? This has been written through the ASCO guideline and the ESC guideline and is still as a recommendation. And did they have an echocardiogram between 6 and 12 months after completing cancer-directed therapy? So essentially follow-up cardiac assessment for those who are at higher risk. And then treatment. Do we treat these patients appropriately, particularly those who develop cardiovascular complications or are at risk of complications? And I think this is somewhat harder to think about or to measure, but we could look at things such as referral to cardio-oncology clinic if someone actually develops cardiac dysfunction, and we can look at did they get the appropriate medical management and appropriate imaging. So here is a cardio-oncology checklist that was from the same paper that sort of helps us look at what are the simple to-dos that we may consider before, during, and after cancer therapy. And these really speak to some of those quality indicators that I mentioned in the previous slide that are possible indicators that we could use. And of course, there's barriers to assessment of quality indicators. So lack of provider buy-in, lack of resources, and importantly, variability across healthcare settings, including challenges specific to rural versus urban areas, so that we know that there are very few cardio-oncology services available, at least in rural North America. So how do we assess quality when our patients are having less access than those in urban centers? Patients are evaluated by clinicians across multiple disciplines, including hematology, oncology, cardiology, primary care. So how do we align the quality indicators with the individual healthcare providers the patient is seeing? And how do we advocate for consistent quality metrics or ascribing primary responsibilities for these metrics? So who's going to measure them? How are they going to measure them? And how will we collect that data? And then, of course, our patients travel. So as I alluded to previously, some may be treated by a local oncologist in a rural setting. How do we ensure that they have the follow-up assessments that are appropriate based on the quality indicators that we're measuring? So achieving, I think, consensus and support for common quality metrics is really going to require collaboration and a concerted effort among cardiology, oncology, and primary care societies. But I think importantly, if we want to advance the field and we want to show that cardio-oncology is added value, and this is becoming a very prominent field right now, we have to start thinking about how we are going to measure what we are doing. So my take-home messages in terms of just an introduction to quality indicators in cardio-oncology is that I think the discipline of cardio-oncology has entered into a new era where we're focused not just on quantitative measures, but qualitative measures of care. And I think this aligns well with other specialties that in medicine that have developed quality measures over time. Developing and applying quality metrics in cardio-oncology are essential steps toward improving patient outcomes. We need to be able to go back and demonstrate that we are actually having a positive impact on overall patient care. And this ICOS ACC document really serves as a first step in advancing quality metrics in the field. I think it's just the beginning. We need to continue to work on this. And I should say that the ESC also published a few years ago a paper looking at quality metrics in cardio-oncology as well. So with that, I want to thank you for this short talk, and I will remain on the line for our active discussion in a few minutes. Thank you.
Good morning, and thank you, Dr. Susan Dent. A great presentation. Just one comment from me before we ask the audience is like we can understand like for treatment and diagnosis, we know who is going to do it. But in your practice, who is it who does the risk stratification or the health assessment?
So I think it's going to even vary amongst practices across, even North America. But do you mean in terms of the cardiovascular risk assessment? I think that would be my healthcare team, which consists of myself and a nurse practitioner. So when I see a new patient and they're just about to start their cancer treatment, I work with my nurse practitioner and we do the cardiovascular risk assessment at the beginning.
Yeah, but that is like you are a medical oncologist, right? So is this, what
Yes.
about the other, I mean, I just want to know what is the, practice overall in other centers? Meaning, you are different in the sense you are a medical oncologist and a cardio-oncologist, but it may not be so at all the other centers. And the patient will first report to the oncologist. So,
Yeah. So I think here's the key. I mean, I think that, once the patient is referred and seen in a cardio-oncology clinic, they have to be referred by somebody. So how do they get to the cardio-oncologist, right? So that may be either, rarely is it self-referral, but you need to understand, but it really has to come from the oncology team, particularly as they're getting that patient established for their cancer therapy. So if we really want to sort of look at risk stratification of patients prior to starting cancer therapy, you need to get your oncologist on board to do that, because otherwise the patients will not even be seen by the cardio-oncologist, right? They will never get there.
Yeah, so basically the oncologists are the one that's trainee oncologist, the budding oncologist, or practicing oncologist will have to be trained in this risk stratification, because as a cardio-oncologist, you'll not be able to see all patients. So the patients will be referred based
Correct.
on this. So any questions?
Correct.
Basically, the local physician, see, medical oncologist is a physician. Every physician would know how to really risk stratify patients. So the idea of risk stratification may not really lie with the cardiologist to start with. The risk stratification can be done by the oncologist, the baseline risk stratification, and subsequent to that, if he finds that there is a problem or something, then he can be referred.
But that is the issue, na, sir. In practice, is it being done? I mean, people can ask, and it should be done. So it is basically incorporating cardio-oncology in the curricula of cardiologists and oncologists may be the way forward with the pace.
Right. And so I think, it's not being done. It's not being done necessarily everywhere, but one way we can do it. So is in the United States, at least, we have cancer therapy plans where the chemo is written in the plan. And one with the majority of us moving towards an electronic medical record,
that would
we
be a
have
great thing.
before we can incorporate that into their treatment plan, so that as you're getting them ready for their chemotherapy or their targeted therapy, we can have this as a checkbox that they have to have the stratification done. I think, the more automated we make it, the better, because oncologists already have so much that they're trying to do when they see a patient. So,
There should be a
yeah.
by default drop down in the system, the EMR, where the patient first reports, and you could train people to do it actually. Yeah.
Dr. Susan?
Sorry, sir.
Dr. Susan is the doctor.
Yes.
Dr. Rakesh here. Let me tell you that you have been doing a fantastic job. So how is your cardio-oncology clinic right now? How do you do your work? Who all are involved? Like nurse, how is it organized? It will be beneficial for the audience.
Yeah, so we have a cardio-oncology clinic program here, and the way it works is that if a patient's at high risk or if you have concerns about cardiotoxicity, we actually have within our EMR a cardio-oncology referral tab. So we can just simply put in a request for a cardio-oncology referral, I have a advanced practice nurse who then will look at all those requests and then triage them based on how quickly they need to be seen. So if it's urgent, someone who has had significant cardiotoxicity, well, we can usually get them in within a week. If it's less urgent, within a few weeks. So I will have to say that one thing you do really need is good communication between the cancer team and the cardio-oncology team. And also within our EMR, we have this function where we can call it's a secure chat function. So if a provider is really concerned about a patient, they can send us an email or the secure chat, and we will deal with it, usually within 24 hours. So that communication has to be, the more that we can facilitate it being electronic and not having to pick up a phone, because none of us can be near a phone, but I think that's so important. You have to have that person sort of in between that really brings oncology and cardio-oncology together, and that facilitates that. And so I really do heavily rely on our cardio-oncology nurse practitioner.
Okay, thank you, Dr. Susan then. So in the interest of time, we'll move to the next session.
Thank
so
you.
I would like to invite Dr. Aruni Ghosh. He's a clinical fellow at Bart's Cancer Center and clinical research fellow at the Bart's Cardio-Oncology Service, London, UK, and co-founder and chief medical officer, OncoFlow. Over to you, Dr. Aruni Ghosh. He's speaking on cardio-oncology, MDT.
Sorry, but where are the slides? There you go. No? Good stuff. Right. So Dr. Gopal and Dr. Savant, all the questions that you answered, and thank you, Susan, for answering half the questions of my talk on transforming the cardio-oncology MDT. So please allow me the opportunity to go walk with you through the cardio-oncology MDT and the referral system and the risk stratification and the education of cardio-oncology components to the team. This is me. I'm a jack of all trades, master of none. I have a medical oncology hat, a cardio-oncology hat, a cancer health disparities, sustainable oncology and cardio-oncology systems hat, as well as an AI and oncology hat. And that's quite multidisciplinary, which then goes on to the next slide. I love prostate cancer, and I was involved in the Bart's Cancer Center 10-year experience on prostate cancer, MDT, which is from there we moved on to Arjun and then the cardio-oncology MDT. So the big question is, who's the part of the cardio-oncology MDT team? So on one side you've got service, and on the other side you've got research. You've got real-world evidence generation, and you've got service. So coming to the 2017 paper, when Arjun started the Bart's Heart Center, Bart's Cancer Center, Cardio-Oncology MDT in 2016, that was our team, which we still follow today. And then our colleagues in Spain, Pons Rivarela, give us a good highlight of what the team is about. So it's not just cardio-oncologists, it's also about EP specialists, intervention specialists, cardiac surgeons, so the entire spectrum over there, and research nurses, service-based nurses, and MDT coordinators. Moving on, so I think we now have an understanding of what the team is. The next slide will show you the service framework. So we're lucky to have Arjun at the Bart's Heart Center, which is the largest heart center in the whole of Europe, and a Cancer Research UK Center of Excellence, which is the Bart's Cancer Center. So as you can see, if you look at the three models over there, so this is the model that we follow, where it's staffed with cardiology and oncology, both in-house. So that would sort of mean the ideal system, ideal service framework, and it's quite labor-intensive, high on funding. The next model that is there, so that's basically has an oncology base with a cardiology referral, and as you can see, that's more towards your survivorship, more towards your post-treatment. The other system is over here, which is a cardiology base with an oncology referral system. I don't know how sort of sustainable that model is. Moving on to the next slide. So now we've got an idea about the team, and then we moved on to the service framework. And then we would move on to a sort of a roadmap, as in, if you would picture the disease entity, you would want to have what's there before treatment, what's the care that you would want to provide before treatment, what's during treatment, and what's after treatment. Cancer survivorship is on the line, and you want to figure out what the late effects are. So these are diagrams or a schema talking about the different stages and what the different roles of them are. In the interests of time, I would like to move on to the next interesting slide, as how do we sort of educate people about the specialty of cardio-oncology and what the different roles are from the cardiologist perspective, the oncologist perspective, and the general perspective. So general perspective, so in the UK we've got, and this is from a paper which we just submitted and has got our intellectual property. We just submitted to Journal of Cardio-Oncology this roadmap over here. And that's the US-based system they have in postgraduate year 4 to 7. So internal medicine trainees, internal medicine doctors in the UK would have knowledge as to just an understanding of what the cardiac implications are and recognition. And then you have the oncologists, the hem-oncs, the solid-oncs, as well as the cardiologists having an intersection in your advanced cardio-oncology competencies, which you sort of see in this slide. A sort of a mix and match of both, trying to find the common intersection. And we have a special exam, I'm sure you've heard about it, the international, the ICOS board examination. We've got a manual for that as well, for being certified. Going on to, in the interest of time, I'll just skip this. This was the landmark Titan study, which was a trial which was done in the cardio-oncology multidisciplinary team space. In the interest of time, moving on to a template. So as we were talking about how is this referral sort of managed, so it's the oncology. So how I see the cardio-oncology MDT is an oncology-powered system where the cardiologist's role would be to support us through the cancer treatment as much as possible, and looking at two very big endpoints. One is the quantity of life, and the other one is the quality of life. Still maintaining your oncology endpoints, but also keeping your cardiac endpoints in balance as well. So this is one slide, and I just want your eyes on the question for the MDT. So you've got the background, you've got the holistic medication, etc., the investigations, the presenting symptoms, and I want you to take a deep look at the question over here. And the question simply states: is there evidence of checkpoint-induced myocarditis and cardiac dysfunction? This was not done by me. And I'll take you to the other one, which was done by myself. So you've got the background, you've got the presenting complaint, but look at the questions. And the questions are, very, very pertinent. These are the answers that you would want from your cardiologist. And the questions are, what's the risk stratification? And once you've risk stratified, okay, what are you going to do from an oncology perspective? And what are you going to do with regard to the cardioprotection? And this is a slide, as I think Dr. Sawant, you pointed out, who's going to sort of recognize, what your baseline cardiovascular risk factors are. I've covered the slide on the quantity of education that you need to empower your oncologist to be, and this is along the lines of what Susan Dent mentioned as well. So that's the pathway of how you sort of refer to the cardio-oncology MDT in the UK, and that's the same system which we do in the US as well. So whether, again, the concept of risk stratification. And I think the landscapes changed from the early 2000s, where there were a few oncology drugs to, I don't know, we don't keep up with the lung cancer drugs anymore, I think. So that, that's where we are post-2020. And this was our example, and we've just submitted this paper to Cardio-Oncology. And that's your Bart's Cancer Center, Bart's Heart Center model with UCLH. So we share our cardio-oncology services. So as you can see over here, I mean, this is the cardio-oncology referral that needs to be sent, and that's to be done specifically by the oncology team, which would have a sort of a not a diagnostic completeness, but a holistic 360-degree view with your investigations, whatever you've done, etc. And then going on to your pre-MDM case manager, the MDT coordinator, and you push it to the MDT. And those are the participants of our MDT, and it's usually a very, very big MDT. You can see all these are the constant people in the MDT, except this one in italics, because that's the variable person. So the treating oncologist is always a different oncologist. And this was a statistic. So we carried out a one-year evaluation of our practice from 2023 to 2024. And it looks like, the solid oncology portion is a bit more than the hemato-oncology portion. And going on to this slide, this one talks about, what was the reason for discussion, so about treatment safety or procedure needed, and these were the landscape of procedures. But I really want your eyes on this, these amount of figures. So when we talked about treatment safety, you can see that 90% of our patients had treatment continuation with cardioprotection, and that just shows the amount of cardiological support that we need to empower the oncology treatment with. And this sort of echoes with what Vivek said earlier about how can cardiologists support oncologists and having the best of outcomes. And only 10% had treatment temporary cessation. Going on to this one, so taken from Avi Guha's paper on the spectrum of cardio-oncology services, I think we need to identify the cardio-oncology entity. And once we identify that, whether it's ICR-related myocarditis or anthracycline-induced toxicity, we need to sort of risk stratify it into mild, moderate, and severe. And those were the questions that I asked when I referred to my cardio-oncologist. And then the third question you need to figure out, what's the prognostics of the disease course from the oncology side? How much of overall survival do you have left? And how much of treatment can you still go? What's the likelihood of what lines of treatment do you have left? So you need to have a good understanding of the oncology endpoint. Going up to the intervention, so from the cardiology side, it's cardioprotection, it's procedures, and from the oncology side, it's about the treatment fate. Moving on to what is I'll just finish, I'll just wrap up in a bit. Moving on to, innovating the cardio-oncology MDT. I know Arjun talked about the Cardio-Oncology Innovation Network. Question is, how can AI be the next frontier? So this is what I explained to you in the talk when Dr. Parekh was asking me questions about data extraction and treatment matching. And this is a very important slide on standard of care. So the cardio-oncology MDT has to define their standard of care. It could be ESC guidance, it could be local protocols, and you've got to match your data to the SOC. And that's a sort of multi-agentic AI system which sort of could be the next frontier. The bottlenecks, large-scale real-world validation, integration into the EHRs, that's the problem we're facing. The longitudinal data challenge is another problem of artificial intelligence into the cardio-oncology MDT transformation. I'm a bit sandwiched between Susan Dent and Kay Sharma, and there you have a map of the USA and China, and I just want to put it to your attention that from 2000 to 2016, we've got a growth of 100 to 166 centers, cardio-oncology centers in the USA, and China had its first cardio-oncology center, and Kay would cover this in her slides in the year 2016 to 2017. And what she's done is that within 6 years, we've established 30 cardio-oncology clinics with iCardio-Oncology. And the reason why this is important is a bidirectional ecosystem, which we're talking about, from resource surplus to resource constraint settings to keep the balance up. And this is another very important slide on how it started in the US, how iCar started this in Tampa, Florida, about how you have different networks, you have different stakeholders, service, clinical trials, about the knowledge-sharing model, which was so well implemented, and Kay will talk about this as well, into the cardio-oncology knowledge transfer model. Take-home messages. Obviously, the most important thing is we need to build capacity. We need to educate our oncologists as well as our cardiologists to a common intersection point and ask the right questions in the MDT referral. In the era of cancer survivorship, We need to amplify our services. Every center needs to have a cardio-oncology service, especially during the times of rising ICIs and cardiotoxicities. I think we need a collaborative effort, saving costs, data, connectivity, and time to create sustainable ecosystems. And that's the end of my talk. Any questions?
Yeah. I think in the interest of time, we will take questions during the panel discussion only, and let us,
Yeah.
move to the next talk.
Okay. So coming up next is Dr. K. Sharma. She's a Chief Medical Officer at SANMED, Executive Director for the International Cardio-Oncology Society China Chapter, Shanghai. And she will be talking on developing international collaboration, cooperation in cardio-oncology, Chinese stories. So over to you, Dr. K. Sharma.
Asian Cardio-Oncology Society, Asia Pacific Cardio-Oncology Society Summit on the 15th and 16th November 2025, the Golden Tulip, Salt Lake City, Kolkata. I extend my congratulations to all the delegates and the leadership for arranging this meeting. And it's such an honor for me to be part of this, and I apologize I cannot be there in person. However, I look forward to meeting you all. And to briefly introduce myself, I am Dr. K. Sharma, the Chief Medical Officer of SANMED and the Executive Director of the International Cardio-Oncology Society China Chapter. And I currently lead and run the China Cardio-Oncology Program. And my talk today will be about leading the cardio-oncology program and development in China and our model of expansion. Thank you so much for your time. So the background of cardio-oncology in China: cardiovascular disease and cancer are the two leading causes of death worldwide, with significant improvements in cancer survival rates. Cardiovascular disease is now the second leading cause of death, and long-term morbidity and mortality amongst cancer survivors. So this diagram is the whole world cancer 5-year survival rate. And in 2022, there were 4.8, about 5 million new cancer cases and 2.5 million approximate new cancer deaths that occurred in China. And the incidence of cancer in China continues to increase. And despite the development, there is still a big challenge for cancer survivors, highlighting the urgent need for progress in cardio-oncology. So although it's challenging to have a cardio-oncology program in China, however, it's very necessary to do. So the model that we utilize, which has proven effective for enhancing medical disciplines and specialties in China, is this knowledge transfer model. So it's really important. It's made up of 7 components. The first component is establishing a society in China. So how have we done that? The first workshop was a sprout of cardio-oncology in China, where it was published in the local newspaper that over 30 hospitals were interested. And due to this impact, we got a endorsement from Dr. Susan Dent, which led us to the establishment of the first cardio-oncology conference, CCOC, in 2016. And we had the honor to invite Dr. Susan Dent and Dr. Anna Barrick to China to be able to mark a milestone in its development. So because of this ongoing initiatives, between 2017 and right now, 2025, we have over 30 cardio-oncology clinics. This diagram is yet to be updated, and now we have surpassed the 30 society marks. So we have over 30 cardio-oncology societies, and yes, clinic establishment I will talk about later. So because we have been able to establish the Cardio-Oncology Society, we're also able to carry out and conduct corresponding doctor education and training programs that must be registered through the society. So what have we done so far? So the first thing that we have done is a multidisciplinary collaboration model. I have created this model based on the breakdown on oncology specialties, cardio-oncology subspecialties, and also the cardiac subspecialties. So very briefly, in terms of cardio-oncology, cardiotoxicity, multidisciplinary integrated care, cardiac imaging, and integrating Chinese traditional medicine and Western medicine are all key. And in terms of the clinical application of this, cardio-oncology MDT, including different interdisciplinary departments such as cardiology, oncology, pathology, radiotherapy, rehabilitation medicine, basic research, and so on. However, these multidisciplinary specialties are also expanding to include different subspecialties such as emergency medicine, surgery, and so on. So Cardio-Oncology MDT meeting happens once a week where we share knowledge, conduct case discussions, and educate each other. And based on that, we were able to create a cardio-oncology consultation process, which is currently used across different hospitals. This one in particular is used at the Dalian Medical University affiliated with the First Hospital, and is to perform cardiovascular risk assessment for patients, including a complete medical history, baseline assessment, LVEF analysis, and electrophysiology studies, including biomarker analysis. And this would lead to multidisciplinary patient care. So another aspect of cardio-oncology collaboration is primary and secondary prevention. And this is a system that I've created and put into place, which incorporates optimal cardiac surveillance, patient risk assessment stratification, combining the ABCD approach with survivorship and having a holistic cardio-oncology collaboration, not just for patient management, but also for prevention. And prevention is also a very important part that has been endorsed by ICOS and is on the agenda for this year and the future collaboration. So prevention and monitoring system of cardio-oncology, this is an algorithm that has been developed, and it is broken down into 3 components: scientific research, clinical management, and education and training. And this further breaks down into different multidisciplinary specialties. And the patient can be monitored before anti-cancer treatment, during anti-cancer treatment, and post-anti-cancer treatment. And this will lead to ongoing scientific, clinical research, collaboration, and so on. So access to knowledge is important. We have yearly Cardio-Oncology National Week, and we also have translated the Cardio-Oncology ESC guidelines, and we've also translated resources such as books and other training materials for doctors to use. So we've also created doctor-led media that we publish on WeChat and online social media, because these are very popular means of education in China. So this is an example of a doctor interview that we've done locally. However, we can definitely collaborate to do this internationally as well. So the third part is the patient education. After we train and educate and train the doctors, only then we can train and educate the patient. So far, we have been very successful in hosting charity clinics, and these happen during the Cardio-Oncology National Week, which is in June. And we have education of cardio-oncology services, societies, activities, and even introducing ICOS to local Chinese patients and the initiatives that we do. So these are a few pictures of seeing patients and performing simple assessments. And then once we have the patient trust, only then patient compliance and patient their encouragement into actively participating in clinical trials, clinical research, is a very important and necessary part of cardio-oncology expansion. So currently we're conducting 6 multi-center studies. One is a multi-center clinical trial of prevention of cancer-associated VTE, clinical trials on cancer treatment-associated hypertension, a multi-center study on cardiac biomarkers predicting anthracycline-induced cardiotoxicity for lymphoma patients. Again, multi-center studies for breast cancer patients, open-label, multi-center phase 2 clinical trials for patients with advanced malignancies, and finally, randomized controlled multi-center studies for efficacy and safety of treatments in patients with high cardiac risk factors. So there are more multi-center studies to be designed, which I am very involved in, and it's my pleasure to extend invitation to international experts. And moving on, clinical consensus and clinical practice guidelines. So far, we have over 20 guidelines in cardio-oncology. I think now this number has substantially increased, and I have also co-chaired and co-authored clinical consensus statements and clinical practice guidelines, and I'm currently translating guidelines from Chinese to English to be published on online platforms. And healthcare partnerships is a very important aspect to be able to have doctors from different provinces and different international societies link with Chinese doctors. So what have we done to achieve that? So we have collaborated with various international organizations. ICOS is a society where I put China's cardio-oncology on the global map. And the ESC, we have also collaborated with them. We're in partnership with ISTH, Global Sepsis Alliance, Radcliffe, Asian Geriatric Oncology Society is our new partnership, and as well as various journal publishing houses, including PMJ, Waters, Kluwer's, and so on. So this is our most recent partnership in 2025. It's our honor to collaborate with Dr. Parekh. And this is Radcliffe Cardiology. They have wonderful webinars for cardio-oncology. And Dr. Arjun Ghosh established this, and it's been going really strong right now. And then finally, cardio-oncology clinics. Once we have all the necessary tools, training, education, and trials, research in place, then we can establish cardio-oncology clinics successfully. So currently we have over 30 cardio-oncology clinics cross-provincially. I really hope these numbers can increase. And once we establish more clinics, we will move on to the future development. And we also want to congratulate a new clinic that recently opened in 2025, November. This is Hunan Cancer Hospital's Cardio-Oncology Clinic. So because of the clinic establishment, we have access to knowledge where we know in the clinics the largest patient populations are breast cancer, lung cancer, gastric, colorectal, connective tissue, and soft tissue malignancies, followed by liver cancer according to their corresponding percentage. And based on these patient populations, we can look at more targeted therapies and understand how these patients respond to these therapies. So these are all very important advancements that we've been doing. And now we're very proud to talk about AI screening in cardio-oncology. So we have released a cardio-oncology GPT that has been used in First Affiliated Hospital of Dalian Medical University. However, its development is still going on. And now there's been a pipeline for creation of augmented large language models. And this paper is written by Dr. Arurup Guha and also Arani Ghosh. And the Cardio-Oncology MTT and Artificial Intelligence Transformative Collaboration involves large-scale real-world validation, which is necessary to be able to mature these AI algorithms. So the next step is to create ICOS Centers of Excellence and certification of clinics. So I was very honored to visit the Cardio-Oncology clinic of Dr. Arjun Ghosh, which is a gold standard clinic. And based on his practices, I really hope to follow suit and to bring ICOS standardized clinics to China. And the future practice and priorities, creating cardio-oncology working groups, we have already done that. And because of that, we're expanding into multidisciplinary working groups. So this is Mr. Afford from the ESC. The CSC CEO came to China and we established these working groups together. And these are our few plans. And I'm very proud to say that we brought cardio-oncology to the ISTH Congress China Forum in 2025 that we hosted. And it was the first time cardio-oncology was on the agenda. So this is our authorization letter, and this is the agenda. And I invite all of you to come to the ISTH 2026 Congress in Paris, where we will also be hosting, and cardio-oncology will be a very big part of this as well. So I would like to take a few words to talk about the new Journal of Cardio-Oncology that we've launched. I have established and designed the International Editorial Board, and the co-editor-in-chiefs of this journal are Professor Yunong Xia and Dr. Susan Dent, and the deputy editors of this journal are Dr. Michael Fradley and Dr. Arjun Ghosh, and I'm the international advisor. It's my honor to invite all of you to submit your articles. And finally, I'd like to say a few words regarding a new initiative that we've launched. So traditional focus was on single organ protection. However, through the China Anti-Cancer Association, at the CCHIO, we have launched a program for advancing organ protection competency in cancer care. So now we will introduce a system-wide approach, redefining cancer care from treating the tumor to protecting the whole patient. So it's a very important multidisciplinary collaboration that we will follow through. And this is the agenda that we had. Thank you so much for your attention. I look forward to collaborating with all of you. And yes, I really hope to advance cardio-oncology together. Please do message me and get in touch with me with your questions. Thank you.
Thank you, Dr. K. Sharma. That is, congratulations on your amazing work. And we would now move on to the panel discussion, for which I will invite Dr. Anuprita Daddy. She is the Associate Professor and a Consulting Physician at Tata Memorial Hospital. Over to you, Dr. Daddy. She will introduce her panelists.
Good evening, everyone, and welcome to this very special panel discussion on establishing cardio-oncology multidisciplinary team and collaboration. Disclaimer, I don't have any data or any case to discuss today. So for me, this session holds a very personal connection. My journey in cardio-oncology began long back in year 2009 under the mentorship of Dr. Aruna Alari Dheer. Okay, and then I had a privilege to do preceptorship in cardio-oncology under Dr. Susan Dent, and this was in year 2014, who is with us here today, and you heard her before. And that inspired us to have a cardio-oncology clinic at Tata Memorial Hospital, where I continue to work with an incredible multidisciplinary team, including Dr. Sheila Sawant, who is chairing the session today, Dr. Nandini Menon, who is also in our panel, and we also have intervention cardiologist coming once a week. We also have medical oncologists from different DNG, Dr. Prabhat, Dr. Lingaraj from HIMAT, GI, and we all meet together once in a week for discussion of high-risk patient and get inputs from all over, so that patient doesn't have to move to other OPD and we save time on patient. And since then, I had an opportunity to attend a global cardio-oncology summits every year, and most recently, just 2 weeks ago, in Cape Town, again with Dr. Susan Dent. Now, it has been long, fulfilling learning curve, and I'm truly grateful to the organizers for this opportunity to moderate such a unique session. We are joined by an exceptional panel of leaders from across the world, each shaping cardio-oncology in their own region, who hardly need any introduction. So let me start. Dr. Susan Dent, she's the director of Cardio-Oncology program at Wilmot Cancer Institute, USA, a global pioneer in the field of cardio-oncology, director of ICOS, and my own inspiration in the field of cardio-oncology. Dr. Aruni Ghosh, who is clinical fellow at Bas Cancer Center and now a co-founder of OncoFlow London. Dr. K. Sharma, Chief Medical Officer at SanMed and Executive Director of ICOS China Chapter, Shanghai. Dr. Nandini Menon, who is a professor of medical oncology, Tata Memorial Hospital, and a part of our high-risk cardio-oncology multidisciplinary team. Dr. Ariru Gua, who is a director of cardio-oncology at George Cancer Center, Augusta, USA. I would like chairperson also to be on the panel discussion. Ma'am, please. Okay, this is already. So, and now, my dear audience, I understand it has been a long day of inspiring exclusive talks since morning, and you have all been absorbing a lot. So to keep you engaged, I invite you to join me at a short exploration, a journey into how multidisciplinary team in cardio-oncology can be effectively built, sustained, and scaled, and how global collaboration in shaping the next chapter in this field. I've set this conversation against a fitting backdrop of Calcutta city, a city steeped in scientific heritage and known for its spirit of community and compassion. Just as this city has long served as a bridge between East and West, today we build new bridges between oncologists and cardiologists, between clinicians and researchers, and across the nations and institute, all united by one goal: to improve patients' outcome through collaboration. So, I would like to start from Dr. Susan Dent, who has really led this from Canadian Cardio-Oncology Network to ICOS directorship and now to Cardio-Oncology program at Rochester. Could you please share your experience on how your journey from evolving cardio-oncology program and then key steps in building a sustainable multidisciplinary team?
Oh, thank you for that kind introduction. I think if I step back and look at that photo that you just showed of one of our meetings in Ottawa, Canada, it really brings back a lot of memories. And to me, it brings back the idea of why was I so interested in, building these bridges between cardiology and oncology. And it really stemmed from the fact that I can remember when trastuzumab was approved in early stage breast cancer for those women with HER2 positive breast cancer. And as an oncologist, what we quickly realized is that some of these women were experiencing drops in their left ventricular ejection fraction. And my colleagues, what they were doing is essentially stopping therapy. So here we had a remarkable advance in cancer treatment, but oncologists weren't comfortable delivering that treatment because they were witnessing drops in LVF and they just really didn't know what to do with that, and they were worried about the safety. And it made me really realize that, in medicine, we've traditionally worked in silos. I do my bit with oncology, the cardiologists do their portion with the heart, but we don't sit down and we don't talk about patients as whole individuals. And so that way back, years ago, led to my realization that we need to break down some of these walls. We need to work together as a team, whether that be cardiology, oncology, of course, nursing, pharmacy, and it's more than just, two different disciplines, but it's all about improving patient care and realizing that some of the scenarios that we face and the patients we face, you're not going to find the answer in a textbook. It's not going to be written somewhere, even maybe with ChatGPT, it might be getting easier. But these people are individuals, and those individuals come to their diagnosis of cancer with their unique issues. And so I felt at that point, and I reached out to some of my cardiology colleagues, felt that we really just need to sit down and work together. And, when I told my oncology colleagues this, they were like, wow, this is great, because I don't feel comfortable treating patients with cancer treatment who have drops in their EF, or, they're outside the sort of the normal window or the product monograph which says how these patients should be treated. And that's really how it started. And remember, that was just back when we had to deal with anthracyclines and HER2 targeted therapies. And since that time, my goodness, there's been an explosion of new and novel cancer therapies. All the new cancer therapies, by the way, are targeted therapies. And we're realizing now that with very few exceptions, almost all of them have some form of cardiovascular toxicity. Whether that be hypertension, arrhythmias, myocarditis, we're appreciating that all of these compounds affect the cardiovascular system. And so I think that's what's really driven this field and driven my passion to say we cannot forget about treating the whole person. I want to give this individual cancer therapy, but if they come to me and they already have poorly controlled hypertension, diabetes, dyslipidemia, obesity, they're going to have issues with the treatment that I'm offering them. So how can we work together to provide the best possible care? And I will never forget the challenge I had when I was at Duke University of actually a male breast cancer patient who had breast cancer and a heart transplant. So imagine the complexity of this, treating someone who had a heart transplant on immunosuppressive therapy and they have breast cancer. You were not going to find the answer of how to treat this individual in any book, because these are really rare circumstances. But at the end of the day, you're faced with an individual you have to treat. So by calling up my colleagues, by working together, by having a discussion, we came up with what we felt was a reasonable plan for that individual. And that's really what it is all about trying to find, I say sort of, we're talking about personalized medicine these days, particularly in oncology. I think personalized cardio-oncology is really what we're looking at. Is, yes, we can follow pathways for these individuals, but in some cases you cannot avoid, the necessity to speak and work together to come up with a reasonable plan. And so, as you know, that's exploded from, a few clinics in Canada and the US to now many, many clinics around the world. And it's so exciting to see the growth of cardio-oncology internationally. And as we witness that, my call would be also to don't forget about low and middle income countries as well, and in rural areas, because those individuals also deserve access to cardio-oncology care. So I think that's going to be our next challenge is, yes, in urban centers and large cities, we have access, but what about in those smaller rural areas and countries which have limited resources?
Yeah, thank you so much. And let me ask you one more thing. Like, you being an oncologist, what were early challenges you faced aligning your cardiologist and oncologist in your field, your area?
It has been a challenge, and I wrote an article or a commentary piece a few years ago in the ASCO Post called Cardio-Oncology, Where Are the Oncologists? I think if you look at who's driven cardio-oncology, it is mainly driven on the cardiology side. And even within the International Cardio-Oncology Society, 85% of our membership are cardiologists, with a very small percentage of oncologists. So I think there has been a slow uptake on the oncology side, because I think oncologists previously have felt that, they really don't offer drugs that lead to very much cardiotoxicity. And we know that's not true. But I think what has really sort of started to change, I think, how oncologists feel about this is the fact that now we're using immune checkpoint inhibitors just about in every solid tumor type that is out there, and recognizing that these have multiple toxicities, including cardiotoxicity. So I think the oncologists are starting to see now the consequences of cancer therapies from a cardiovascular standpoint. And it really does speak to education of oncologists. Now, I wouldn't expect oncologists to know how to manage these individuals in terms of their cardiovascular toxicity. But what I think we have to do is really focus on encouraging them to refer patients to cardio-oncology, particularly as patients when they're getting into trouble, preferably if they're very high risk. And I think that is, of course, a shift in thinking, of mindset, and so this always takes time. I think our ability to work with other organizations, ASCO, ESMO, other oncology organizations such as MASC. All of this will help to educate oncology providers into the importance of considering cardiovascular consequences.
Yeah.
And, I just keep reminding them, oncology, cancer, and cardiovascular disease are the number 1 and 2 causes of morbidity and mortality worldwide. And so, we naturally have to think about both. And I also think it's interesting, the emergent sciences suggests that if you have cardiovascular disease, you may be at increased risk of cancer and vice versa. This sort of reverse cardio-oncology concept, I think, has also been intriguing and is leading to many oncologists starting to think more about this intersection.
Yeah, thank you so much. It's really challenging to get oncologists and cardiologists together. Dr. Ghosh, you have worked at BARTS with OncoFlow, integrating digital innovation into care flow. What does an effective communication model look like, especially in a large or resource variable setting?
I think we operate with lots of fragmented data systems. So you've got your radiology and your echo and your cardiac MRI in one space. You've got your sort of bloods in one space, and you've got your EHRs. So getting all the data together in your EHR templates and getting the questions right, I think that's what's most important. When the treating oncologist presents the case onto the cardio-oncology MDT, I think that bit of information in the referral is very important because we're the controllers. It's our patients. We go out to the cardiologist and, hey, guys, can you support us through the treatment? So every little minute detail needs to be onto the data extraction template, basically.
Like if you see, I work in tertiary hospital. I'm a phone call away. Like I phone and immediately. But what about the small structured structured hospital who don't have this tertiary NSS? How can they start in a structured manner in a cardio-oncology clinics and all? I mean, how this will just begin where in our setting there are private practitioners also. Like a cardiologist will be practicing and patient might not get an appointment, go to local cardiologist who is not even in touch with any tertiary. So how in our setup it will be?
So let me bring you to the concept of the model which is already in Tata and the National Cancer Grid, the hub and spoke model. And it's a huge hub and spoke model. BARTS and the UCLH, so we're in northeast London and north central London, caters to a big catchment area. We're a tertiary centre, but we get sort of from the district general hospitals, which are not tertiary centres, so we get referrals from their treating oncologists as well onto our catchment area, and it's the same form, same template. They use different systems, and that's why I said, because we use sort of different systems, we need to get that data input right and identify the risk category.
Do you think any role of educating primary physicians?
So I think
general physicians.
I think as you go on to cancer care survivorship models, and this talks about after treatment, when you go into survivorship model from Australian Flinders University and in the Australian setting, when I was part of the Lancet Oncology Commission for Cancer Control in the Commonwealth, there were great survivorship models out there, including cardio-oncology, where there was a role of shared care models between primary care and tertiary care. So there is a great role, but that's in the survivorship setting.
Why can't it be in active, like patient, if he's not known that this could be a side effect, it might go to a primary physician with some chest pain, palpitation, or how you are going to involve in, because in our setup, they only see cancer, I will go to cancer, but others, if they even have fever, they will go to local physician. So in that setting, how this will work?
So if I understood your question right, it's about empowering with education about the family physicians and the general physicians.
In India, it works in that way.
And the resident doctors, like, for example, my juniors. So it's about educating them about, and we generally do mass teaching sessions with in our alliances, in our NHS alliances. We do education sessions about, recognition of
But in this audience, there are no physicians.
Sorry?
There are no physicians who are actually the patient will be seeing. A general physician who will be sitting and seeing the patient who has no idea. We are only inviting cardiologist or oncologist. I'm thinking when we are going to target those where people will primarily see, patient is going to be seen by them primarily,
So
first
I think
contact,
your
then
first.
they have complaints, active complaints, which are not, they might not think they are related to cancer. Is the patient awareness is not there in that case?
So what we generally do for our patients is that in our cardio-oncology clinics, we would always do something called a safety net and symptoms and signs to watch out for. And we would, so our clinical nurse specialists would do the rest of the follow-up decisions with, communicate with the patient. So if they are positive on those warning signs or symptoms, the first point of contact would be a hotline number to the clinical nurse specialist.
Okay, thank you. Okay. Dr. Sharma, leading the ICOS China chapter gives you a unique regional perspective. How can international mentorship and collaboration help bridge the skill and awareness gaps across Asia?
Thank you so much for your question, and thank you so much for having me here today. So mentorship is a really new aspect of cardio-oncology training and practice. But however, matching the mentor to the mentee, it would work. We have had that in China, where we've had multidisciplinary mentors and mentees. So for example, you would link not just the cardiologist with the oncologist, but you would also link, like, for example, a nurse specialist with a junior oncologist, because we have, as Dr. Aruni Go said, that the training and education has to start from as early as possible. So this mentor-mentee relationship is really important. And also introducing local doctors to international mentors to be able to understand the multidisciplinary practice of cardio-oncology, because cardio-oncology now is actually so dynamic. Only it's up to us in middle income and lower income countries to be able to catch up with how dynamic it is globally. So that is one huge way that it's actually a strategy that has worked. And I encourage that doctors in India can also explore this.
Okay, but if you see, China has different way of working, UK has different way of working, US has different way. Somewhere cardiologists are taking lead, somewhere oncologists are taking lead. So do you see any potential for how we maintain a regional registry or academic exchange in that case, when we are seeing different kinds of patients with different comorbidities, different prevalence, and how can we merge those and apply on, like, it will be very difficult if I apply the data on my clinical practice. Well, I will not see a patient, I generally see patient with low weights and all. How do we then share and then come on a single database to apply? I mean, how we get into uniform thing?
That's a really good question. From my knowledge, the Chinese medical practice and the way the distribution is of hospitals across the country is quite similar to India. So here we have provinces. However, in India, I understand there are states. So each province in China would have its regional database, and each regional database would only be linked with other regions and centers across different provinces if there is a multi-center study involved. And that way, each center can exchange data. I'm not sure if this is applicable in India or possible to implement, but that is a way to be able to extrapolate data from one province and to be able to compare patients with different regions around the country. So that is something that has been implemented here, and I'm not sure if you have already been doing this within different states in India or what the current development is.
Okay. Dr. Menon, working together at Tata Memorial Hospital, we have seen complexities firsthand. Now, could you share how oncology workflow can better integrate cardio-oncology consult, and what makes oncologists more cardio-conscious?
So, ma'am, I think the main thing is, like, which has been discussed by everybody on the panel, is mainly communication, that you have to sit together. Dr. Dent also highlighted this. A lot of things that we were sensitized once the cardio-oncology clinic came into place, and the workflow and how it should go about. So I think the first step is, if we decide to establish a clinic, there has to be a communication Also probably look at other models, because in India we don't have a robust, like for example, the NHS has a very efficient primary health level referral model with GPs who refer to specialists. We don't have that in our country. Primary health level, your previous question was whether, how do we train the primary health physician or whoever the patient is going to, we don't have that. So I think communicating and probably highlighting the fact that there is a platform or a team that could look at such problems, because many times cardiologists themselves don't do get patients who go on their own, or they're prior treating cardiologists, and there is no integration between them and what happens here, and it becomes different, especially in our center, because we are a referral center. People come from other states, we don't know what is going on, and nobody is on the same page. So I think the first thing is to have a dialogue. The other thing is probably look at other models of better established and well established cardio-oncology models, and we try to adapt them to our situation. It may not be the same because we have our own restraints with the volumes and how to refer and how to integrate. So that is the next thing. And probably, like you said, not everyone may need cardio-oncologist or a cardiologist to follow up. That is our greatest weakness, both from an oncologist point of view, and also if you look at the cardio-oncology model, is we don't have nurse practitioners, where in the West, a lot of even routine oncology services, especially in survivors or patients not on active treatment, are taken care of by nurse practitioners. We have started employing physician assistants, which is not exactly nurse practitioners, but probably some additional staff where we would train to screen the follow-up patients or guide them in a center where maybe we are not able to see everybody. So I think a lot of work needs to be done, which is not streamlined in our centers.
Yeah, and thank you for discussing on challenging also in a busy cancer institute.
Sorry, if I may.
Yeah.
I think Tata has a great program called the KVAT program, the Cancer Patient Navigator program, in the absence of clinical nurse specialists. So I think cancer patient navigation plays a huge role. Maybe that is something that you guys can look into. And they're friends and families or family members of survivors. I think, huge sustainability over there.
So KVAT is quite robust, but the thing is KVAT is already overwhelmed, the KVAT that we have. So we have additional volunteers who act as navigators, but all of them are non-medical. So they navigate the logistics, the financial, assisting patients, getting to places, getting interaction, but we don't have a kind of cadre where there are kind of medical professionals, non-doctors who are trained. So KVATs do a lot of jobs, and we have NGOs who have volunteers.
But the ratio is also KVAT to patient
is very skewed, so that is another.
Is Dr. Gua with us?
Yes.
Yeah, you have been actively involved in global research and registry. How can collaboration across diverse population help us generate stronger data, and what role you see in for artificial intelligence and digital tools in future multidisciplinary team collaborations?
Thank you first, organizers, for inviting me to talk with this esteemed audience. Been glad to have worked with several of you in the audience, and just to sort of personally say that I trained at GS, which is down the street from Tata Memorial. So I was lucky to have some of the lectures given by Dr. Sawant heard when I was sitting as a med student in the audience. And then Kolkata is my home city, so glad to sort of virtually at least be in my home city. I will be visiting in January with my family for the first time, so I should say all that. But anyways, I've worked closely with several colleagues, including Mike and Susan, over the years on data science. I'm trained epidemiologist as well, apart from clinical cardio-oncologist. And I believe there's a role for the data sets which Arjun talked about in his keynote to be utilized for sort of a more American sort of standpoint. There is British data sets which we have worked on with colleagues like Amitabh Banerjee, who's worked with Arjun, to bring in the British perspective given a nationalized healthcare system. And similarly, colleagues from Canada, including Daryl Leong and Hussam Abdul Qadir, have worked on the Canadian registry, where the data is also stored because it's a nationalized healthcare system. The problem with with colleagues in India would be that absence of nationalized healthcare system. So I think an initiative at a smaller scale with one cancer perhaps might be a way of starting to gather data. And I would imagine with sort of somebody like Susan, who's already interested in doing something like this, breast cancer would probably be one of those cancers where you could start making the momentum. And once you have gathered enough data is where sort of the role of AI, artificial or machine learning or any other form of developing the data into meaningful consumable is something which is what comes next. So I think a lot of the things which we do in general cardiology, general oncology is to sort of extrapolate data from the West into practice in the East, which is something which probably needs to change over time. And I think using sort of a data set driven, high quality approach with real world data and then subsequently doing clinical trials locally would be probably the way to go about developing the field of cardio-oncology locally. A little quick perspective of how I manage my cardio-oncology clinic, because I think folks have asked that question and would be helpful to the audience, as Dr. Rakesh had mentioned. So I actually have a three-people team, much smaller cancer center than Susan's. It's myself, I have a nurse practitioner, and I have a nurse navigator. The nurse navigator essentially collaborates with every single cancer center person to receive the consults. She is a trained oncology nurse who has been able to gather good insight into how the referral patterns is for each of the specialties, and they contact her to get the patients on. I generally see new patients, and my nurse practitioner sees return patients. That way we are able to get patients in cardio-oncology within 1 to 2 weeks into our clinic. So our goal is to basically see patients that soon.
Yeah, but again, the patient compliance and long-term following up will be a real challenge. So, slide is not. So the key, okay, so it's already time up. So the key takeaways is share intent and institutional support builds strong multidisciplinary team. Simple communication system works best. Collaboration must cross border. Training, data and mentorship. Every multidisciplinary team begins with one patient and one conversation. So thank you all. And together, through cooperation and collaboration, we strengthen cardio-oncology. Thank you.
Thank you, ma'am, for really wonderful session, and I think you had really put up very aesthetic slides for this. So thank you. Yeah, thank you. Yeah. So we'll